Hello, everyone. For those of you who don't know me, I'm Dr. Cheryl Kamlick, founder of My Pedia Heart Care Partner. We are a privately owned pediatric cardiology practice that specializes in partnering with medical practices to provide accessible, personalized pediatric cardiology care to families in eastern Pennsylvania and New Jersey. Let's get started. Today we're going to talk about screening for high blood pressure in children. This is a two-part series. The first part is a general overview. Part 2 is a case-based approach to this problem. The objectives we will cover are why we're screening, how to screen, who to screen, and what the initial evaluation is going to be. This presentation is based on the American Academy of Pediatrics AAP Guidelines for 2017. We will be utilizing the level of evidence outlined here, including B and C level of evidence, and we will be providing those recommendations that are strong and moderate. So, blood pressure, why do we screen? About 10 to 15% of youths have elevated blood pressure. In this population, blood pressure just continues to rise over the years at about 7% per year. This problem does contribute to atherosclerosis and its early onset in the young adulthood years. The problem, though, is that less than 25% of these patients with high blood pressure are diagnosed by their primary care clinician. So we really want to improve that so we can have better long-term outcomes for these children when they grow up to become adults. This is a graph representing the blood pressure and how it changes over the years. The general thought here is that children who are hypertensive just grow up to become adults that are hypertensive. That is because the problem changes over the years. It gets worse. So on this graph, from age 7 to 38, the lower bar indicates children who have normal blood pressure, followed by children that have high normal blood pressure. And you see they are staying below the 120 range. However, patients who have elevated blood pressure and those that have significant high blood pressure, they start below 120, but then over the years, they tend to go up, continue to go up, and in some cases, they finally land in the stage 2 or worse hypertensive range. Another reason we screen is to identify those patients who have family history that will put them at risk. One important risk factor is parents who have hypertension. Parents who have hypertension have an increased chance that their child will have hypertension. But the correlation is strongest if the mother is hypertensive. What we find in children that are hypertensive, they do develop some of the same problems that adults do. Looking here, they do develop left ventricular hypertrophy, increased carotid medial thickness, and arterial stiffness. This is an interesting study where the researcher looked at the right carotid artery and the percentage of fatty streak and raised plaques in patients from the age of 15 through 38, 34 in some cases. The gray represents a low percentage of fibrous fatty streaks. The black represents a higher percentage, 10-15%. As you can see, when you have a child between the age 15 to 19, you are having some evidence of these fatty streaks, even at that age. And as you get older, you have more and more and more. The percentage of black here, representing 10 to 15% or more, of fatty streaks goes up. Same as what happens with the prevalence of fibrous plaques. At the age of 15, you don't have very much as far as percentage, but as time goes on, there is more. And even in the young adult years, you have quite a bit of raised plaques in the carotid artery in this study. I feel like this study highlights something very important that we don't really appreciate, and that is that the problems that are set in motion when you are in your early adolescent years, they tend to worsen over the years. And when we take steps to intervene in the earlier years, we may be able to avoid some of these changes. So let's look at how to screen blood pressure a little bit closer. The AAP recommends that you start off with measuring blood pressures regularly. We'll go into a bit more about who we should be measuring it with. But essentially, every year, a child should have a blood pressure age 3 and above. There are certain populations that should have it even more frequently. And that is those who have underlying problems that will put them at risk for severe elevated blood pressure. These include patients with chronic kidney disease, heart transplantation, any solid organ transplant, that is any patient who is on chronic steroids, those that are premature, born premature below age 32 weeks, sickle cell patients, and a lot of other patients. In this chat, I will include the link to follow and get a little bit more information on who should have blood pressure starting at as early as age 1. This diagram demonstrates the proper placement of a blood pressure cuff. So just remember that in your office, for those of you who are providers and you have another individual checking blood pressures, the first 2 blood pressures that are collected typically are with an oscillator device. These devices are not as accurate as auscultatory blood pressure measurements because they actually calculate just a mean blood pressure and it doesn't measure systolic or diastolic pressures. Auscultatory method is a method to directly measure blood pressure, systolic and diastolic. If measured in the correct way, it is the most accurate blood pressure. So if you get an abnormal blood pressure reading on an oscillator method, you are obligated to repeat that with auscultatory methods. A very fast way to do this is what I do on a regular basis is measure the arm circumference and then just look at the blood pressure cuff. And it clearly shows you what arm circumferences are appropriate for that cuff. So one of the most important things you can do is measure that blood pressure with the appropriate cuff. The other thing to remember is that when you're measuring a blood pressure, the arm as well as the apparatus to measure the blood pressure should be at the level of the heart. When the arm is raised too high or too low, the blood pressures are too low or too high, respectively. This is just a diagram showing where you should not measure blood pressures, not at the wrist or the ankle. So the 2 proper places are the brachial artery and the popliteal artery. So once you've gotten an accurate blood pressure, you then go and classify what your blood pressure is based on the AAP guidelines using table 3. I'm going to pause here and have you go ahead and scan the blood pressure required for further checks, as well as scan to read blood pressure table 3. The blood pressures required for further checks is a good, quick way for your staff to look at the blood pressures and know that, hey, these in particular need additional evaluation, so they may bring that to your attention. This is the most accurate way to classify then what blood pressures you have. As you can see on this table, classified by normal, elevated, stage 1, stage 2, children less than 13, and children greater than 13 years of age. Children greater than 13, they generally use numbers as your cutoff. Less than 120/80 is a normal blood pressure for a child who is greater than 13. Less than less than 80, to be clear. Elevated then is between 120 and 129. Over less than 80, the key feature is less than 80. And then stage 1 and stage 2 go up accordingly. For children less than 13, the blood pressures are mostly based on blood pressure percentile, which is driven by height and age. And they're all noted here. Now, don't worry, you don't need to memorize the entire chart. Sometimes that can be challenging to commit those numbers to memory. There are a few good tools that you can use to direct you and how to interpret your blood pressure and the initial steps in management. The one that I like to use is this one. It's by MD Calc. I have no conflict of interest with that company. But I do like this calculator because it is directly linked to the AAP guidelines. We can test one out here. How do you screen for blood pressure and interpret it? Let's try it on this 14-year-old athletic build patient with a BMI of 23 and a height of 67, blood pressure 120/80. When you go to the link, you'll notice that his blood pressure is actually elevated because the diastolic pressure is 80. It's not less than 80, it's 80. I would classify him as elevated without the diagnosis of hypertension. Here's a second one. This patient is a female, blood pressure 130/80. She, based on the calculator, is stage 2 hypertension. The good thing about this calculator, it also gives you guidelines that are in alignment with the AAP guidelines. And in this case, it tells you if this is your first time checking, institute lifestyle modifications, and recheck in 1 week, as long as they are asymptomatic. So, what are the lifestyle changes that we're talking about here? Well, we all know that we tell patients on a regular basis, eat less, exercise more, and the reality is many times it's unsuccessful. And that is because we're missing a key ingredient, and that is focusing on the entire family. The keys to successful lifestyle modification is to focus on the entire family and not to isolate the child. When you focus on the entire family, you are more successful at instituting lifestyle changes that are permanent. Families will play together, eat together, plan meals together, and each person in the family has a role to play. I use the Ellen Salter model. This has been proven effective at various academic institutions. In this model, parents have a role and children have a role. The parent role is to provide food, items and get help with any insecurities they have to obtain food. There are many communities that are out there that can assist parents with that. Although, respectfully, it's not always easy to get that. You do have to be sensitive to food insecurities in a home, because if you're asking them to provide foods with high quality ingredients, they may not be readily available. But in this model, that is the job of the parent. Also, the job of the parent is to set the activity routines for the child, as well as set the time, the place, and what will be on the meal plan. The child has the role of deciding what to eat and how much to eat. They also get to decide what is offered to them, what they will do as far as activity. This model does seem counterintuitive. However, there has been quite a bit of research and my personal experience that tells me when we enforce strict rules, the opposite occurs. When parents insist on shaming the child or hiding foods or things like that, the opposite occurs. The child may not eat it at that time, but they go seek it out. They don't develop normal hunger cues, and lifetime, they end up in a worse situation. So I do highly recommend the methods outlined here. And if you want additional information on this, help for families, I would take a look at the models that are outlined here. The Ellen Sater eating model is just scan the QR code and you can see a little bit more detail. There is parent information on those websites. So you've seen the patient with stage 2 hypertension. You've rechecked the blood pressure. You've initiated lifestyle modifications. Next step being checking an upper and lower extremity blood pressure. And we've already reviewed how to do that. The AAP also now recommends ambulatory blood pressure monitoring. What ambulatory blood pressure monitoring does is gives you a better assessment of the patient's blood pressure over a variety of situations, not just in the office. So the patient wears a cuff for 24 hours, and we obtain data like the systolic and diastolic blood pressure, the mean blood pressure, as well as what blood pressures are happening throughout the night during wake and sleep. And based on these numbers, the blood pressure abnormality can be further classified as normal, white coat hypertension, masked hypertension, or just ambulatory hypertension. Now, normal blood pressure could potentially be a scenario of a child who comes into your office with a blood pressure less than 130/80, and you're concerned, you send them home with a monitor, but in the course of that 24 hours, the blood pressures remain less than 125/75 in the 24-hour period, and less than 130/80 while awake, and less than 110/65 while asleep. Now notice you must have variability in your blood pressures when you sleep, and if you don't have that, that is an indication of potential pathology and potentially indicative of masked hypertension. So a little more on ambulatory blood pressure monitoring. It should be performed on any child with a new diagnosis or a question of hypertension. If you have a child with elevated blood pressure for a year or more, but does not meet the diagnostic criteria for stage 1 or 2 blood hypertension, they also should have an ambulatory blood pressure monitoring performed. It should also be strongly considered in patients at high risk to determine their blood pressure variability while they're sleeping. The hypertension while sleeping puts them at increased risk for target organ damage. So this is valuable information you can get from an ambulatory blood pressure monitor. A few more points with ambulatory blood pressure monitoring is It can also be used to measure the effectiveness of a treatment. So if a patient is being started on a medication, does not seem to work, or if it seems to work in the office and you want to verify that, you send them home with a monitor. It's good for that. This is the device that we use in the office, and here's an example of what readings are obtained in the 24-hour period. It denotes multiple blood pressures. In this patient, it cycled about every 30 minutes to an hour. Based on the patient's preference, they didn't want it cycling continuously. So we don't have as many measurements. However, you can see there's some variability here. And what we should see is dips when it's time for rest, when patients are usually sleeping, and then higher spikes when the patient is awake. We also have a histogram and a pie chart to denote those values as well. So back to the evaluation of these patients. So blood pressure initial evaluation actually depends on what the cause is. So your history and physical exam will give you some clues about what the cause is and therefore direct you for what evaluation you might want to consider. When you're assessing the patient, primary hypertension is the most common cause, and you should start to suspect that in any child greater than 6 years of age with a systolic hypertension, overweight child, or a family history of hypertension. Now, you can have severe elevations in blood pressure with this group. So just because the patient has, stage 2 hypertension or more, it does not necessarily mean that there's a secondary cause. Primary hypertension can also present that way. Here are some very important history and physical exam features that can help direct you to determine if this may be a secondary cause of hypertension. Vital signs such as tachycardia may indicate hyperthyroidism. Decreased femoral pulse may indicate coarctation of the aorta. Proptosis is another potential indicator of hyperthyroidism. Growth retardation and failure to thrive may indicate chronic renal failure. Obesity may indicate Cushing's disease. And to name just a few others, skin lesions, especially severe acne, hirsutism, are consistent with Cushing's syndrome or potentially hyperandrogens. So when you have a moment, review the tables and try to keep a thought as you're examining the patients and getting the history. Could this be a secondary cause of high blood pressure? Here's a summary of some of the important features with renovascular, coarctation of the aorta, and medications and toxins. One important feature as a cardiologist, I'm going to focus on for a second is coarctation of the aorta as a potential source for hypertension. Patients with coarctation of the aorta will present, if there's a significant one, with a blood pressure difference in the upper and lower extremity, and you want to check the blood pressure in the right arm versus either leg. A blood pressure difference of 20 millimeters mercury would be considered significant. This goes along with a decreased femoral pulse, and sometimes you can appreciate a heart murmur. The murmur of coarctation of the aorta is a continuous machinery-like murmur that is occurring over the spine. And you may also have a crescendo-decrescendo murmur over the bilateral lung fields that would indicate potential collateral vessels have formed. One note under medications and toxins, we are very familiar with oral contraceptives, central nervous system stimulants, and corticosteroids as being a source of elevated blood pressures. Lead and mercury can also cause hypertension, as well as some homeopathic medicines and herbal supplements that are available to patients. St. John's worts, sometimes used to treat depression, can cause hypertension. Pennyroyal oil, unfortunately sometimes used for self-abortions, are also very toxic and can cause severe hypertension and as well as multiple organ failures. So again, we're still focusing on evaluating the patient based on the cause. Another significant cause is sleep apnea. When a patient has sleep apnea as a young child, they're more likely to develop hypertension if that sleep apnea is not resolved, and that starts to show itself in the teenage years. The clues to that that you're already familiar with include loud snoring, daytime sleepiness, and reported history of apnea by the parents. Overweight children, large tonsils, these are the children who you would suspect it in. Here's a nice summary of the potential pathophysiology of what is causing hypertension in patients with obstructive sleep apnea or sleep apnea. It is the thought that they have increases, surges in sympathetic activation, as well as increased inflammation and oxidative stress on the blood vessels, resulting in damage to the endothelium. Over time, this leads to hypertension that is difficult sometimes to manage. Diagnostic testing for these particular problems are broad, but at this point, you would likely be considering referring to a specialist. So we've covered why we screen, who we screen, and how to screen, as well as the initial evaluation. This does conclude part one of the objectives of screening children with hypertension. Important take-home messages is that blood pressure of 120/80 is no longer normal. And very important also, the initial evaluation of these patients is based on clinical suspicion. No longer do we just order a collection of tests. It is based on what the clinical presentation is. I hope you've enjoyed this. Part one of two-part series, evaluation of hypertension in children. Part two will include some case studies and a little bit more information on using some of the tools we outlined today. I hope this has been helpful. Thanks for your time.